Very warm good afternoon to everyone. I am very thankful to Dr. Manjunath sir to giving me this opportunity to present in this forum. I know all are very busy practicing pediatricians, so I have made a point to keep it very simple and crisp about the triage in pneumonia. So as we know that triage is a rapid systematic screening of children upon arrival either in a clinic, hospital or at the community setting to immediately identify whether the child is having a life-threatening condition or prioritize to urgent or non-urgent cases. So we have the three parts in the triage. Initial impression by the pediatric assessment triangle, the next is the primary assessment, ABCD approach, then is the secondary assessment. In initial impression, usually it is the hands-off assessment or a doorway assessment, it is called as, where we do not touch the child, but with the visual and the auditory clues, we assess the child based on the three factors ABC, that is the appearance, based on the tone, interactiveness, how is the consolability, and based on the look and gaze of the child, the speech or cry, and on the breathing, whether the child has normal breathing or increased respiratory efforts or any nasal flaring, apnea or gasping, and in circulation, whether the child is pale, mottled or cyanosed. Based on these three factors, we consider it as normal or abnormal, and then we categorize it to stable or unstable. At any point of time, if the child is having any abnormality, we have to stop at that point and start on the intervention part. Like if child is having any increased breathing with retractions, try to start on oxygen if there is a facility, and then move on to the next assessment stage. Second is the primary assessment, the ABCD approach pentagon. The goal is here, primarily we have assessed whether the child is stable or not. Then we'll come to the physiological specific problem. Where is the problem? So in airway, we consider whether the airway is open, maintainable or non-maintainable. Open means usually child will be well talking to us and interacting with us, and if the child is having maintainable means we have to do some positioning or do secretions, do suction to clear the secretions out. If it is non-maintainable, probably we have to opt for any advanced airway measures like intubation or placing LMA. And next is the breathing part. In breathing, we consider the respiratory rate according to the age group. Less than 2 months it is more than 60, and 2 months to 1 year it is more than 50, and more than 1 to 5 years it is more than 40, and above 5 years it is more than 30. So based on the respiratory rate and then work of breathing, the respiratory effort, if we should look for if child has any suprasternal retractions, supraclavicular retractions, nasal flaring, which will point out to the upper airway obstruction, or child has any sternal and subcostal retractions pointing to the lower airway etiology, and if child has intercostal retractions with grunting, probably the lung parenchymal disease. Along with that, chest wall movements we have to see for whether it is symmetrical or not, and followed by auscultation, so whether the child has decreased breath sounds or absent breath sounds, to look for the etiology. Then these are all the clinical signs which we look for. Pulse oximetry is the measured sign. Usually less than 94% is considered hypoxemia according to pulse. Next I will tell the differentiations. Next is the circulation part. We look for heart rate, delayed capillary refilling time, and blood pressure, whether it is low or normal, and the central and peripheral pulses, whether the skin is warm or cool. Next is the disability part, where we look at the neurological functional status of the child. based on the cortical and the brainstem function. Cortical function is usually assessed by the GCS or AVPU scale, where we see whether the child is alert or only responding to commands, or whether to the pain, or child is unresponsive. Then we also look for the motor activity, any seizures, posturing or flaccidity, symmetrical or asymmetrical movements. Then for brainstem functions, we look for the pupillary light reflexes. Then is the point of care testing, if it is available, blood glucose GRBS to be done. And exposure, usually we look for the core temperature and the color and the surface findings, if any, along with fever, any rashes or boils or any other findings we may see. So in pneumonia, usually the first one to affect in the initial assessment and the primary assessment is the breathing part, and as later on the severity worsens, it will affect all the other parameters also. So after the primary assessment, then we classify the severity and triage. So we have to look for either the child is having respiratory distress or it is falling into respiratory failure. In respiratory distress, usually airway will be open without any required support, and there will be raised respiratory rate, tachypnea, with increased efforts of child having retractions, and usually lung sounds can be clear or crepitations may be there, and heart rate will be, there will be usually tachycardia. Usually child will have some agitation and irritability, and appearance, child may look pale based on the exposure temperature. In failure, usually the airway may be maintainable or obstructed or non-maintainable. Respiratory rate, usually there may be bradypnea because of the prolonged hypoxia if not treated early, and respiratory efforts may be very much decreased, and child may be gasping, and lung sounds, there may be abnormal sounds, stridor, wheeze or any grunting. And heart rate will be usually from tachycardia, it would have gone to bradycardia because of the prolonged hypoxia, and child fails to respond for the commands, and usually child will be cyanotic at the failure level. And apart from this, along with the failure signs, if the child have hypotension and central and peripheral pulses not palpable, maybe it will go into cardiorespiratory failure and arrest. According to these signs, we triage the classification. Level 1 is resuscitation. Usually the respiratory failure child will come for the level 1 resuscitation. Sometimes even respiratory distress ongoing to failure, and level 2 is emergent with respiratory distress. Level 3 is urgent only with tachypnea and chest indrawing. Level 4 is less urgent, maybe only cough, cold along with fever. And 5 is non-urgent without only cough and not having any other symptoms. So this is at the hospital level. What we use commonly is the IMNCI, everyone is used to it, at 3 color triage signs, pink, yellow and green. When the child is having no cough, one child is having only cough or cold, and there is no chest indrawing or fast breathing, it is being triaged as green, no pneumonia, only the OPD management. We tell the mother about the general danger signs, and to come back and show in the OPD again after 5 days. And at the second, at yellow triage is the when child is having chest indrawing, and when the child is calm, fast breathing, and there is no general danger signs, that is the pneumonia. We triage it as yellow, where we can treat on OPD basis with first starting for amoxicillin, oral amoxicillin for 5 days, and educate the mother about the home management, and tell to come back after 2 days if any for the follow-up, and to look for any general danger signs. Then if child is having any general danger signs, unable to drink, convulsion, vomiting everything, and stridor in a calm child, then it is usually triaged as pink, very severe disease. Along with this, if If oximetry is available, if measured, then less than 90% saturation, central cyanosis, or child is only responsive to verbal commands, pain and unresponsive, it is triaged as very severe disease or very severe pneumonia, and immediate either admission or referral to the hospital facility is required. Along the way we can start on oxygen. If there is any wheeze, we can give nebulizations, educate the mother and tell the mother to keep the baby warm, and refer the child. This is at the community level. So after this, if at all, if the child is in the hospital, then we can move on to a secondary assessment, which is more helpful for identifying the specific etiology and about either respiratory, cardiac or neurological function. So based on the focused history examination along with the appropriate lab diagnostics, we can identify the specific etiology and start on the concern management. So this is what a basic pediatric emergency triage generally we do in hospitals. We follow the in a nutshell, general assessment first. The initial impression, we categorize it as stable or unstable based on ABC. Then the primary assessment based on ABCDE approach. Then the categorization into stable, respiratory distress, failure, shock, or primary brain or cardiorespiratory failure and arrest, and triage them and start them on the required management. At any point of time, if the child is having any abnormal sign, we have to stop at that point, start the treatment and then continue the assessment. Thank you. Yes, sir.